I'm Todd Didier, Communications Director at the Primary Care Collaborative. Every month, the PCC recognizes outstanding leaders who are working to improve the nation's health by strengthening primary care. This month, we're thrilled to recognize Brenda Brennan, a medical anthropologist and psychiatric nurse practitioner working in primary care for more than 45 years. Brenda is also a member of PCC's Whole Person Care Work Group, which explores strategies for the promotion of whole person primary care. Brenda, as a champion of whole person primary care, you've helped lead the integration of mental health at Intermountain Healthcare. Could you start by painting a picture of what that looks like?
Thank you, Todd, and appreciate this opportunity to share our story. Actually, this is a story of many champions. Mental health integration at Intermountain has had actually 25 years of successful history as one of the most robust and advanced mental health enhancements in the United States with strong published results. But its culture of normalizing mental health as a routine part of primary care has been implemented and sustained. Ultimately, it was our goal was to build high functioning, trusted teams where health is not only just efficient and effective, which we were pretty good at, but is delivered and governed through relationships that make people feel truly cared for. And I think the best way to paint for you a picture of what it looks like is how it feels by sharing the voice of people who, when seeking help from their doctor about something emotional or physical, have experienced this type of care. So I'd like to read you parts of a patient's testimonial. Let's call her Sarah. She's 72 years old. I believe my doctor was actually the first doctor that has ever really cared about me as a whole. Instead of just take these drugs and I'll see you next year, he really has taken the time to listen to all my symptoms and all my history. And then we put a plan together. I've been going there for 3 years. And even though we don't live there anymore, we, her family, travel down there just to continue to go there. Now, my mom had depression, and people around her made her feel like she was less than whole for having to take medications and that therapy was only for people who had schizophrenia. I've grown up thinking it's my problem and it's me just feeling nuts. So having my doctor make it like a day-to-day thing and that it's not my choice or brought on by something that I didn't do, it's actually a physical thing. He said, if you had cancer, you would not treat your cancer because you're nuts. You need to take care of yourself. And he made it more like a human thing and something I can deal with. He made it easy for me to talk about things I really wouldn't talk to a doctor about. He's a good listener, open, and when I needed more than meds, he hooked me up, connected me with other good listeners that worked right here with someone he knows, trusts, and he talks to. So my whole world does not revolve around my depression and my pain from arthritis anymore. It revolves around the things that I want to do with my family and my family. The biggest change I've noticed is with my family. It has really helped my family get the most out of life.
It's, I think, demonstrative of some phenomenal work that you have helped lead at Intermountain, and particularly your work on mental health and behavioral health integration. Could you maybe tell us a little bit more about how how you were able to help build a program that was able to deliver that approach that you just shared with us?
So the beginning is the inception of MHI, which is the acronym for Mental Health Integration. And it began with a brave and collective act of reciprocity. Back in 1998, esteemed community primary care providers who had just joined Intermountain's medical group and were very, very reputable in the community. But they raised their reputable voices and challenged Intermountain's leadership for improving patients' access to community quality care. These primary care doctors collectively declared to the leadership that they were on board conceptually in redesigning for quality improvement for chronic diseases like asthma and diabetes, but chasing separate diseases was non-negotiable for them. They were not the whole burden of what families like Sarah's came into their practices struggling with. So they asked Intermountain, What are you going to do to help us with the domestic violence, the substance use, the anxiety, and the depression that our patients come in with in their diabetes visit? So, in an act of collective leadership, the CEO of the medical group did something quite unexpected in healthcare. She took them seriously. She understood that the most important thing that she could do to improve quality in her health business was to build trusting, continuous relationships with her doctors. So she extended an act of reciprocity. She needed them to join her in improving the quality of care. And what did they need from her? They needed improved access to mental health. In essence, the inception of mental health integration. She then commissioned and resourced a team of diverse primary care docs, including patients and families like Sarah's, to help self-organize and determine a path forward. And the path forward was, we're going to make mental health routine. You come in for your sore throat, a diabetes checkup, and we're going to check on your mental health too. Same medical appointment, same medical appointment, same mental health appointment, same trusting relationship. So Intermountain, we intentionally designed for the integration of physical health and mental health, mind, body together. We didn't create a program down the hall. It invested in teams functioning as whole teams to treat people whole.
This has been a program that's been ongoing for a while. With enough exposure over time, could you tell us what kind of results have you seen from this work that you've
Yeah.
helped champion?
The implementation of the culture of the MHI relational operating culture established rules and norms. And so we had care process models. That was a team-based care process model. We also had a diabetes care process model. We had the separate ones, the depression one, hypertension. But this was the first time we built a team-based care process model that included all the diseases, all the concerns, and really embraced the complexity of patients like Sarah and her family, of their life story. And we trained everyone to do mental health. Everyone had a say in building that the group and the implementation team that was convened by the CEO. And everyone had an obligation to do mental health. Even the receptionist who heard the mental health concerns as families called for their doctor, they had a say and they had a responsibility to make mental health normal and a part of every visit of the whole health of every patient. So yes, we started out with we need access to mental health. And the outcome was we were able to have patients feel whole health. The outcome was the experience of whole health. So patients like Sarah and her families that were exposed to, and this is important, a continuous years of the high functioning teams working at pulling the complexity of their life stories together, which included emotional and physical. The teams that supported and her trusted doctor, his practice staff, her and her family, and empowered them together to provide the whole person care. So this cohort of patients, compared to patients that were seen at Intermountain, but in traditional solo practices that still did their diabetes and their asthma, but it wasn't a team-based process, they experienced significant results, which were published in JAMA in 2016. Sarah and her family were not in the ER or being hospitalized. They were adherent to diabetes care or their arthritic care. They received diabetes and depression care plans that were actively worked on with care managers that were on the team and educators that were on the team. They were screened for depression, which activated their depression care plan. And 80% of the normal depression care was provided by their primary care doctors and the staff. The educating, the preventing, the uplift, and extra teams were available to then transition or stratify to extra needed care. This team-based care implementation cost Intermountain $22.19 per patient per year, and it saved Intermountain $115 per patient per year. So this was not only significantly improving in quality and efficiency, it significantly for the whole system of Intermountain reduced the cost and was an incredible efficiency cost benefit as well. These robust outcomes contributed to the evidence that was cited in the pivotal 2021 NASIM report on high quality primary care, showing that team-based care, integrated care, is both achievable and well worth it. Now, the Primary Care Collaborative and the National Academy of Science Standing Committee on Primary Care and others in the field are taking the work and moving it further and making sure that there's policies that shift towards enabling this type of whole person care, which is delivered through high functioning teams. And we know that it's possible.
Taking a step back, we've talked a lot about the work that Intermountain has done and the phenomenal success that's occurred there. But part of that is, your work and being a champion and being a real advocate for this approach. So, curious, what drives you? Why are you so passionate about strengthening high quality whole person primary care?
I feel that I have a strong sense of the healing value of family and the knowledge of family and local communities and their ability to heal. And Sarah's family, and I love telling her story, and there's multiple other stories, they were recognized as whole and treated and cared for as whole. And because that was made possible in primary care, and I'll explain that in a second why I think that happens there, she defined her biggest outcome. The outcome, in her words, is that it helps my family get the most out of life. And to me, that is rewarding, to be able to see patients have not only a relieved burden, still have challenges they have to face, but feeling like they and their family can get the most out of life, as hard as we know life can be. But the other thing that I'm passionate about is that I really learned from my 45 years of actually living and working and breathing primary care that primary care is a strong, vibrant holding environment for family health. So back to family systems and family health. It's a social hub of like trusting relationships. It's a safe place. Many families have their first conversations of not feeling alone, like Sarah did, like she was nuts, or not feeling left alone when they're dealing with complex life issues. And it's the first time they bring up something that's maybe sacred or scary about mental health or the emotional things that are happening in their family. And so primary care to me naturally provides the conditions for mental health, the mind body healing to go together through these continuous trusting relationships. And I believe that trust is really our most precious resource and that we still have the opportunity to replenish that and preserve that. And it's often enduring over generations of relationships with primary care. The other passion that I was able to experience and continue to have is the healing benefit of wellness and the value of belonging. I got to belong to this incredible team, that's why I started out with like we're a group of champions. There were champions in leadership. There were champions in office managers, in nurses, in the care managers, in the mental health experts, in the family experts, in the community, our community partners that said, we want to learn how to do this. So every step was empowering. And we built mental health. Mental health integration became like an identity. And so we kind of built this community.
What do you see as the most pressing challenges in primary care today?
Before I talk about the two challenges that I see right now for primary care, I want to do it in the context of two realities we're living with. The first reality is that the heart of primary care is trusting relationships. And I do not think any of us would argue with that. But the other reality is that trust in our health institutions, in our industry of health, is fraying. 68% of Americans have some little or no trust in the healthcare industry and often experience it as purposely uncooperative and confusing. So we have a huge challenge to be able to preserve what is the most incredible resource and benefit of primary care, to be able to take in the complexity, the nutrition needs, the exercise needs, the spiritual needs, everything that primary care is really good at recognizing and integrating. So the first challenge, I think, is for the primary care providers and teams that are trying to continue to work in primary care. And the challenge will be, that I see, is preserving the mutual benefit and obligation of helping others, which is really the heart of what we're talking about, and finding fulfilling meaning in our work and our daily life. So this means surviving together and having folks in these environments that we want to honor and have be a common good so dearly, of not being alone. And so staying connected in the community, staying physically and mentally well enough on our own to be able to adapt to this adversity and prevent giving up. And to prevent giving up is being able to find a way to join or build a team to continue to help people feel truly cared for. The second challenge is all of us concerned about primary care and concerned about whole health, keeping our eyes and our hearts on the shared purpose of building a social environment and the relational governance conditions that produce trust and sustained wellness. We cannot get there unless we actually recognize and build the conditions that are needed to get to whole health.
Closing us out here, I just want to finish us off with what is my favorite question, actually.
I know
Uh,
what you're going to
so,
say.
yes. So, if there's a lot. I just mentioned the American health system is very complex. There's a lot that needs to be fixed. But if you could wave a magic wand and change one thing about the American healthcare system overnight, what would it be?
I believe in magic, but not magic wands. But I do believe in the magic and the energy and powerful of an enduring social movement that's born and created out of despair and isolation of vulnerable people. And mental health integration, as an example, spread rapidly in Intermountain, not just because we had great data and we had great published outcomes, but it was relieving a collectively felt burden of fragmentation. And we had collective action, which renewed hope for wellness. So whole health to me is spreading on that continuum and is the natural outcome of highly quality integrated care. And it's not only the outcome of integrating and developing a culture, it is the antidote. So whole health is the antidote to actually sustaining wellness over time. So to sum it up on my side, I think joint recognition for whole person primary care as an essential common good is non-negotiable, and it has to be governed as a fundamental human right, not just seen as a human right, but governed collectively by all the voices involved as a human right. And I think that I would love to see, and I am confident we will see this, is the reflourishing of ongoing primary care networks that recognize, reward, and sustain whole health interventions and innovations.
Thank you so much for joining us today, Brenda, and thank you for your long-term commitment to really lifting up and improving the health of the community you serve and so many other communities across the nation. I know that we at the PCC are grateful to you for a variety of reasons, but your leadership is not least among them. So,
Well, thank you very much for this opportunity, and I continue to be there with you. We'll just keep going.